NU318 genetic contributions to psychiatric and behavioral disorders. This is chapter 13 in your textbook. All right, so psychotropic medications is kind of how they're starting off the chapter here, talking a little bit about pharmacogenetics and pharmacogenomics. So psychotropic meds have kind of an unpredictable reliability in treating patients with psychiatric disorders. You might see some people who respond really well to a medication and other patients who really don't respond very well. And also the side effects tend to be potentially severe in some people and not in others. So recently a study of schizophrenic patients showed greater than 74% of the patients stopped their meds. It was either because it was not helpful for them, so it wasn't alleviating or controlling their symptoms, or they had intolerable side effects. So that's where the genetics and genomics come into play for medications, and we'll talk a little bit more about that as we get into the specific disorders. Not taking medications as prescribed for patients with such as schizophrenia results in an increase in relapse to more than 5 times that of the person who is adhering to their medication schedule. So you can see that there's a big risk in folks who don't take their medicines. Some of the potentially severe side effects that we see with psychotropic medications are weight gain, tardive dyskinesia, leukopenia, and metabolic syndrome. And leukopenia can be very dangerous, as you all well know. It's unclear how genetic variations really affect the way people respond to their medications, and we really do need better data because a lot of variables come into play. Environment can interfere, and the ability to obtain your medications can interfere, of course, with adherence. But drug response genetic testing is looking at how medications interact with your genetic mapping or your genetic makeup. It can help personalize medication selection. It's not really widely done yet. There are studies that are looking at this, but sometimes the results actually conflict one another. So we're looking at different biological pathways, enzymes. So it's really, really complex, and it's kind of cutting edge research. But look for this to really become more common in the future. Genetic testing, DNA-based testing, looking at diagnosing single gene neuropsychiatric and developmental disorders such as Huntington's and Fragile X. We know we can use genetic testing to look for that. But as far as psychiatric diagnoses, testing for psychiatric diagnoses, we really don't have good tests at this point. We can help to identify at-risk family members, however, and again, we can maybe lead to new treatments by identifying folks with certain genes that respond to certain kinds of medications. Single gene neuropsychiatric and developmental disorders refer to like the Fragile X and Huntington's that we can identify through genetic testing. There's also the issue of direct-to-consumer tests that we're seeing widely available, as we talked about a few chapters ago. Now, if you're looking at direct-to-consumer genetic testing for psychiatric disorders, this can be really problematic because someone could get one of these tests and think that they're tested positive for something like bipolar disorder, and they really don't have any counseling to help them interpret the results. So there is a test that's out on the market, or it's trying to be put on the market. It's looking for the presence or absence of a single nucleotide that has been associated with 2 to 3 times the risk of getting bipolar disorder, and so that's out there. And the consensus amongst the experts are that these genetic tests are just in the very early stages. It would be really helpful to have them, of course, to aid in assisting. It's hard to diagnose some psychiatric disorders, but the tests that we have, they have very little reliability. or validity, so it's all in the very early stages. So I guess the take-home message from this lecture would be that there's no magic bullet or one single test like we saw with the other disorders that we've been talking about. It's really complex when it comes to the psychiatric disorders. Moving on, behavioral genetics. This is the study of the way in which genes influence behavior, and it's important to note that genes do not directly control behavior. Some gene variants do influence behavior, particularly in combination with the environment. So it's looking at the complexity of all of those things working together. The first disorder we're going to talk about is autism, ASD, or autism spectrum disorder. Autism is a set of collection of symptoms that are patients have difficult with social interactions, like I'm having right now, trying to explain myself. It's also the language development is, there's difficulty with language development in autism. And I'm sure all of you listening have had some experience with an autistic person. It's often accompanied by a narrow range of repetitive behaviors and interests. PDD is pervasive developmental disorders like Asperger's, Rett's. So they're a little bit different, but in my mind, I just think of autism spectrum disorder sort of collectively, all of the disorders that fall under social interaction, developmental delay, repetitive behaviors and interests. Seen as a collection of symptoms and hundreds of neurological symptoms. Phenotypes vary, so prevalence is difficult to estimate. It's common in Fragile X, and a specific genetic cause can be identified in only 25% of the children with autism. So there's not a huge clear-cut genetic component here. So where does autism come from? Well, tetragens, chromosomal abnormalities are about 5%. Copy number variants, which is about 10 to 20%. Single gene neurologic disorders are about 5%, and single gene variants working together with the environment are kind of collectively where we put all the others. When assessing genetics and autism, a 3-generational family history is a good idea to have that recorded, and it's important to assess any developmental or autistic disorders within that family to see if there's any kind of familial pattern. So here are some examples of known genetic causes of autism spectrum disorder. The chromosome abnormalities, copy number variants, single gene disorders, and metabolic conditions. And this is in your textbook. There is some gender variation. Autism is 4-to-1 in terms of male to female ratio. Asperger is 14-to-1 in terms of males to females. Twins, interestingly enough, monozygotic is 70 to 90%, and dizygotic is 10% in terms of the genetic connection there. Environmental exposure, it's really complex and multifactorial. Exposure during pregnancy with valproic acid, terbutaline, and thalidomide seem to have some connection with autism. Regressive onset autism, which is about in 30% of the patients, the symptoms begin between 18 and 24 months. So if you are familiar with the MCHAT screening tool, if you have kids and they may have done that at your pediatrician's office, oftentimes it will be done at 18 months and then repeated again at 24 months or 2 years. Okay, so let's see here. Let's move on to the next slide. So finding genetic associations, looking at neurodevelopmental genes, ion channels, neurotransmitters, and again, the importance of a family history, a 3-generation pedigree, also helps us to look at addictive disorders, social and psychiatric problems, and all those things that may contribute to autism. Okay, Attention deficit hyperactivity disorders, ADHD, again, another diagnosis I think most of us are familiar with, or at least have had some experience with. This affects about 5% of the children worldwide, and it's problems with social interactions and academic performance. In order for a diagnosis of ADHD, observed behaviors must be inappropriate for the child's age and developmental level. So, and it must be present in a variety of situations. ADHD has to be diagnosed by a professional. There are several screening tools that are available for teachers and for families to bring in, and those screening tools can be scored, and working with a professional, the diagnosis can be made. So if a kiddo is just really having difficulty at school, but does all their chores at home, follows directions well, can sit down and put a jigsaw puzzle together, ADHD is unlikely. There may be a learning disability or a specific learning disorder that isn't identified, and is just being passed off as ADHD. So it's important to really get a good history and work with a professional who is well versed in diagnosing ADHD. There are subtypes: inattentive type, hyperactive and impulsive types, and then of course the combined types. And oftentimes we see ADHD associated with other disorders like autism. It tends to run in families. There's no obvious transmission pattern. It's complex and multifactorial, as we talked about. GWAS have found associations on 10 different chromosomes, and there's evidence for a region on chromosome 16 also. So there is some genetic association starting to come with the research that is new and upcoming. Copy number variants, duplications, and deletions are also being looked at, as well as development of neurons and transmissions across synapses that biologically are causing ADHD, or the symptoms of ADHD. So understanding all of these origins of such symptoms would help us improve treatment. Instead of just giving all kids stimulants, maybe some kids need stimulants and other kids don't. So moving on to schizophrenia. Schizophrenia is a severe chronic psychiatric disorder. It usually has psychosis, or not usually, it does have psychosis with hallucinations and delusional behavior. Often it's diagnosed in late adolescence and early adulthood. There's a wide variety in phenotype. It's very complex. Epigenetic changes, might explain the tendency to develop schizophrenia. There's really no lab test that can determine if someone has schizophrenia. We don't know that much really about this disease, to be honest with you. Looking at epigenetics is the variations outside of the DNA sequence itself, so things that alter gene expression by altering different proteins. So that's what we mean by epigenetics. And those sorts of things can also be heritable or inherited by about 80%. So just because it's not a DNA thing doesn't mean it's not heritable. About 80% heritability with schizophrenia. And environmental, there have been epidemiological studies on schizophrenia that support that the environment does indeed play a role in the risk of schizophrenia. So obstetrical complications, birth in urban environments, and birth during famines. Also some perinatal infections and advanced paternal age, believe it or not, might contribute to the development of schizophrenia. So looking for genetic associations, it may vary from person to person. Copy number variants may be involved, histocompatibility complex, especially the 6p22.1, the Notch4, neurodevelopment, and other genes involved in the formation of synapses, again, like we talked about with ADHD. Also, the genes that are involved in neurotransmitter synthesis or signaling might also be identified as playing a part in the development of schizophrenia. So really it looks like there's an overlapping of all of this genetic contribution that might come into play when we're looking at why certain people develop schizophrenia. This is also in your textbook, this slide, or this table. This is the estimated risk of getting schizophrenia when a relative is affected, and you can see general population 1%, but if you're looking at identical twins, 48%. So there's definitely some heritability that we can identify. Affective disorders. Affective disorders, major depression, and bipolar disorders, or mood disorders are what these are referring to. Many families report a history of both depression and bipolar disorder among their relatives. One analysis of many GWAS is genome-wide association study. So one analysis of several GWAS found a region on chromosome 3 that was associated with both depression and bipolar disorder. Major depression. 1 in 6 persons in the United States suffer from major depression. Twice as many women as men suffer from major depression. There are subtypes. You have major depressive disorder with psychotic features and postpartum depression. Heritability seems to be about 50%. Bipolar disorder. Bipolar disorder is where you have episodes of mania and depression that usually cycle, and patients cycle in and out of depression and mania. And mania can be very, very variable. It doesn't mean just being excited or agitated. It can mean different things for different people. An easily distractible, agitated, high-risk behavior, hypersexuality, out-of-control spending, and psychosis. Bipolar disorder seems to be 60% and 85% heritability, depending on the statistics that you're looking at. Environmental risk factors tend to be associated with bipolar disorder, recreational drugs, self-medicating, and genetic influence on addictive behaviors, which we're going to be talking about coming up here next. Bipolar disorder is more common among children born to men of advanced paternal age. So this increased risk could be caused by epigenetics. The father's exposure to environmental stressors over time can affect maybe the methylation of DNA, and that could be why the offspring develop bipolar disorder. Bipolar disorder is highly polygenic. The dopamine D2 receptors also come into play with bipolar disorder. The phenotype is variable and, again, multifactorial. So we're looking at a number of things that contribute to bipolar disorder and how patients respond to treatment. So many genes, each contributing a small effect that can cause the bipolar disorder. In some patients, the dopamine drugs have been used to treat people. So if they are resistant to other therapy, sometimes they respond to the dopamine drugs, and that might be explained by the dopamine D2 receptor defect. Moving on to addictive disorders. 13% of the U.S. population is addicted to nicotine, which I just find really interesting. In people who have psychiatric illness, that percentage is higher, like anywhere from 30 to 60%. Substance abuse disorder is described as an out-of-control drug use that is not consistent with adaptation and continues in spite of serious adverse consequences. Oftentimes, patients will have what is known as a dual diagnosis, so they might have an addictive disorder plus bipolar disorder or personality disorder or defiant disorder, conduct disorder. So dual diagnosis is really common when you're looking at addictive disorders. Years ago, I worked for the VA in addiction and recovery. I worked in the inpatient unit, and it was really uncommon to have somebody with just an addictive disorder. Most of the patients had dual diagnoses. And that would make sense because sometimes with bipolar disorder or schizophrenia, patients are trying to self-medicate using illegal substances or alcohol. So, all right. Alcohol dependence. It's a complex and multifactorial problem. You're probably getting sick of hearing that term, but it seems to be a common thread when we're looking at all the psychiatric disorders. There definitely is an environmental contribution to alcohol dependence. The heritability estimation is 50 to 60%. If a first-degree relative who is alcohol dependent, if you have a first-degree relative who is alcohol dependent, your risk is 3 to 8 times the risk of general population in developing an alcohol dependency. So that's a significant risk factor there. The ALDH2 deficiency, this is a mutation in aldehyde dehydrogenase, and that's an enzyme defect. It is the first genetic information that we had on alcohol dependency. The ALDH enzymes metabolize, or they help break down alcohol, and if you have less effective enzymes, like with the Japanese population they studied, they had facial flushing and vomiting and kind of an adverse reaction to alcohol. So on folks who have the ALDH2 surplus, if you will, or enzymes that are super effective, they don't have the reaction to alcohol that folks with this deficiency have. So that was really some of the first genetic information that we had regarding alcohol dependency. There are genes that encode the neurotransmitters, the GABA and acetylcholine, and genes of the endogenous opioid system, which is affected with alcoholism. So with externalizing psychopathology, there's a group of gene variants that are specific for alcohol and drug dependency. So if you're using certain medications like naltrexone, it blocks the action of these endogenous opioid systems, so therefore it's effective in the treatment of alcohol. So this concept I find a little bit confusing. However, the thing to remember is that there's a group of gene variants that are responsible for alcohol and drug dependency. And perhaps in some people, by working on manipulating the endogenous opioid system, we have more successful treatment of alcohol and substance dependency treatments. Okay, moving on to personality disorders. Personality disorders, I just find this to be really, these are frustrating. They're really hard to diagnose, and they're really, can be really difficult to treat. Personality disorders are collections of socially distressing feelings and behaviors. 10 to 15% of adult Americans meet the criteria for at least one personality disorder. So it's behavior that is different from what is expected in a person's culture, and it results in difficulty managing basic activities of daily living. These are lifelong patterns. They may not respond well to medications or therapy. At one point, these were considered to be entirely learned behaviors, so it was a behavioral thing. Again, complex and multifactorial. Difficult to identify a clear phenotype, so there's no real genetic test that tells us whether or not a person has a personality disorder. The categories are debatable. They share common core factors. Personality traits tend to be heritable, and children often share environment. So there is an environmental component to this. Here are the personality disorders, how they are broken down. Cluster A, odd and eccentric, so paranoid, schizoid, and schizotypal. Cluster B is more dramatic and emotional, like antisocial, borderline, histrionic, and narcissistic. Cluster C is more the anxious and fearful folks who are avoidant, dependent, and obsessive-compulsive disorder. Antisocial seems to be more prevalent in men, and borderline seems to me be more prevalent in female. Heritability varies. In cluster A, there seems to be 30% to 60% heritability. In antisocial, there tends to be 75 to 80% heritability. Sometimes it's considered a spectrum of disorders with common traits, and again, the antisocial 3 times more common in men. Borderline 3 times more common in women. So there tends to be some patterns here that we see with the personality disorders. The diagnoses are based on the behavior. It doesn't always follow the criteria. There seems to be a significant genetic contribution to the risk of developing a personality disorder, but also the non-genetic environmental risk factors play an important role. Many people have more than one, so it's a little bit difficult at times to tease it out. So summarizing the psychiatric disorders and the genetics of psychiatric disorders, I would really want you to remember that it's difficult to treat due to the different responses and medications, and it's difficult to diagnose many of these disorders as well. Genetic studies are promising in helping clinicians diagnose and treat, but at this point there's no real clear-cut tests for identifying psychiatric disorders. Thanks very much for your attention.